that's the reason why, this conversation is important for people, of faith from the Synod and from all other sorts of community organizations. So what I'd like people to do to try to take this concept, health is larger than healthcare, and what does that mean, and try to get it into people's own lived experiences. So I want you to take 5 minutes to reflect on the factors that affected you and your family's health, both clinical medical things and health behaviors, social and economic factors, physical environment. What are all those things that you can think of having an impact on yours and your family's health? And then actually we're going to have you to break up into partners and share some of that information. So we'll do that first 5 minutes now, and then Greg, if we can have them split into pairs, in 5 minutes. So at 2:42, we'll split up into groups. Okay.
Dr. Manriquez, did you want to be in a group?
Well, good. So let's talk a little bit about how to conceptualize some of those experiences. And so this is the onion model. This is adapted from the work of Kamara Jones. And so at the core of it, the inner peel, you have genetic inheritance. So that's what people are born with, or what they get from their parents. And it's worth noting that, this also includes the field of epigenetics. And what epigenetics are is really the recognition that people's social experiences actually get encoded in their DNA, and that those changes are heritable. So if grandma goes through a famine, that's actually going to change the DNA that's passed on to your parent and then to yourself. So that original concept of nature versus nurture, it's really been, it really should just be discarded, because nature does not recognize the distinction that social context always matters. So outside of that genetic and epigenetic inheritance, we have behavioral factors. So you all are talking about many behavioral factors. So what are some things that you could consider as behavioral factors or behavioral choices that can affect your health? And you can use the chat, or you can feel free to call them out.
Nick, whether you smoke or not, or something like that, or?
Yeah, sure. Smoking, absolutely. Yeah, so if we think about smoking, diet, exercise, right, all the things that you're supposed to do or not do to be healthy, kind of usually thought about on an individual level. And so behavioral factors are one thing, but as several of you mentioned, as Linda mentioned, and as Jane had mentioned, the choices that you have in front of you are not in a vacuum, right? And so those decisions are influenced by what resources you have available, and what what the culture supports or doesn't support. And so the next layer out then are what we call the social determinants of health. So these are all resources that affect people's behavioral factors and affect what options and opportunities they have in society. So what are some social determinants of health you can think of? Resources that you might have or not have that would affect your behavioral choices and thereby genetic inheritance and health.
Availability and access to food.
Yeah. So it's one thing to talk about eating a healthy diet. It's another thing to actually have that diet available to you. So I can say, you should eat healthy, and it should maybe be that Mediterranean diet, and make sure you get plenty of fish and extra virgin olive oil. But that predisposes that includes with it a lot of assumptions about capacity. And so some of these social determinants we talk about are in neighborhoods. So Jane, you mentioned, having a community that's actually supportive of a healthy diet and has done that as a group. Access to healthy foods, housing, employment, education, and healthcare. Right, in our society, as was mentioned, access to healthcare is not a universal, is not something that can be taken for granted. So healthcare itself is a social determinant, because it's a resource that is not evenly or necessarily equitably distributed. So these are what we consider to be the social determinants of health. Yes, you had a question?
Would transportation go underneath here?
Sure, yeah.
Mm-hmm.
Yeah.
Okay.
So
people don't have it. A lot of people don't have it.
Right, and if the city or the community is built with the assumption that you have a car, then you're really advantaging or disadvantaging certain groups of people
Mhm.
who don't have that access, or who had that access and now maybe are sick and don't have that ability anymore, and then what happens to them?
Mhm.
So these are kind of the social determinants, but it's important to recognize, in the same way that behavioral choices don't happen in a vacuum, that these social determinants are not evenly or randomly distributed in society. So you weren't born with your 330 millionth parcel of housing. What access you have is determined on, historically and into the present, how society values or doesn't value different groups and different people. And so that's what we call determinants of equity. Those categories by which people more or less matter or more or less count in society. So any thoughts on what would constitute determinants of equity?
Ethnicity.
Yeah, absolutely. Yeah.
When I was young, it could even be determined by your religious preference.
Mm-hmm.
I grew up in a neighborhood that was dominantly Catholic and Protestant, and when some Quakers were moving in, a petition actually went around the neighborhood to prevent them from moving in.
Yeah. So those things can change over time, right? I think,
Yeah.
In structured religious discrimination is less of a thing these days than before, although maybe that's less true when you're speaking about,
Muslims and
Muslims
Islam.
who follow Islam. So, but yeah, these things can change over time. So, we're thinking about determinants of equity, homophobia, racism, sexism, classism, ableism, gender identity. So these are all different, ways in which certain groups count and certain groups do not. And so, another way of thinking about these are systems of oppression, right? So racism is a system of oppression whereby certain groups are elevated and certain groups are not, and the utilization of institutional force which affects the allocation of resources. So to think about that 40% of health that's impacted by social and economic factors, it's really these determinants of equity that play sort of a governing role on what resources you may or may not have available to you in the social determinants. And then those resources then impact both the options and the likelihood of those behavioral choices. And so, and then those behavioral choices impact your underlying genetic and epigenetic susceptibility. So if we were to follow all that through, so racial segregation in the United States, housing segregation by race, makes possible all sorts of differential access to resources, from transportation to housing to employment to healthy food. And those things impact people's behavioral choices in terms of what's a safe neighborhood, what access is there to healthy food, for diet and so forth. But also, if we're thinking about smoking, the tobacco companies have admitted that they target poor and poor and minority communities for their sale of products. And then that's going to affect the genetic inheritance and also whatever historical trauma is carried through genetically from one generation to another. So one of the issues that we have in healthcare is that we tend to focus primarily in these first two circles, right? So we have a model which is patient to provider. And so I'm going to deal with your underlying risk of diabetes, and I'm going to deal with that by telling you to eat a healthy diet and making sure you exercise, and if those things don't work, I've got some medications that we can use. But I have much less to say and much less capacity to impact, how can we make sure there's a rec center where you live, or that there are sidewalks so that you can go do your walking or do your exercise, or that the neighborhood is safe so that you feel like it's okay to go out and do those things. And much less than we have a prescription for racism, sexism, or classism. So, and what we see a lot of in healthcare is the physicians and providers kind of focused on those two areas. And then for all of these other problems, social determinants, determinants of equity, we'll just have the social worker help with that. And so it's not surprising that we're very ineffective in addressing these problems, because you take all the resources towards the inner circles, and then you tell the social worker, you're going to have to solve institutional racism, and I'll take care of the blood pressure medications, right? So that's not really effective. So if those are all the things that impact health and cause inequities in health, so then what is health equity? What does this concept of health equity mean? And so again, off of Kamara Jones's definition, health equity is the assurance of the conditions of optimal health for all. So that's at once an active stance. Somebody has to be doing the assurance of those conditions, the creation of those conditions. And so I would argue that that is the responsibility of all citizens in a community, all people in a community, regardless of their citizenship status. And then it's also a direction, right? It's also a North Star. This is the goal that we have for ourselves, is that we want to create a society in which there's the possibility of optimal health for all, and whatever that entails. And I would submit, and maybe I'm biased as someone who's focused in health, but that the assurance of the conditions of optimal health for all is about as good of a reason as I could come up with for why have our complicated civilization in the first place, right? Like those things that we can't solve on our own, that we can't solve at the level of the family or extended family, we come together and we develop technology and we create all sorts of changes to the environment to accomplish something. And it seems like the production of goods and services pales in comparison to like the purpose of us coming together and structuring our society around the assurance of conditions of optimal health for all. Because, as we love to say, as long as you've got your health, at least you have your health, right? That's a fundamental need and a fundamental goal. So, we've talked about some of those concepts, equity and what that looks like. And so now let's just look at an example of inequity. So this is a study by Wolf down at the bottom, the health impact of racial disparities. And so what they did is for the 10 years between 91 and 2000, they compared age-adjusted mortality between African-American and white people. And what they were trying to do here was to say, if everyone should have equal access to health, then any difference we see between African-American and white people is a disparity, is an inequity. And that gives us an excess mortality. And if we multiply that excess mortality by the African-American population, we can create what they call the excess death rate. And that is all the people who died in excess of white people as a standard because they were Black, right? So it doesn't say why, but it just shows that this has happened. And what they wanted to do is they wanted to say, well, that seems like an important thing to look at, but how does that compare to the benefits we get from medical advances, right? So maybe there's an inequity, but maybe medical advances can sort of smooth all that out and everyone will come out just as well in the wash. And so they compared that to the decline in mortality rate, and they basically credited all decline in mortality rate as due to medical advances over these 10 years. So they came away with two numbers, 886,000 and 176,000. And that first number, 886,000, is the amount of excess deaths that they found in the Black population compared to white over 10 years. So you divide that by 365 and by 10 years, and you get a number of 242 excess deaths per day. That's the racial inequity that exists. And then if you look at that second number, that's the actual decrease in mortality, which is fully attributed to medical advances. So that gives you 48.4 lives saved per day. So you can see that there is that the benefit of medical advances here, even in the most generous sort of categorization, is 1/5 of the actual cost of racial inequities. So, so to contextualize how bad is society in terms of the creation of inequities for the literal death of Black people, at a rate of 243 per day on top of their white counterparts. And you might think that, well, maybe there is some other thing besides racism which explains that difference between African Americans and white people. And so that's why we need to talk a little bit about, well, what is race actually? And what is this? What are we really measuring when we're talking about this difference between African Americans and white people? So race and racism. So just this concept. So I want people to take 5 minutes to discuss in pairs kind of what actually are we talking about when we say race, and what are we talking about when we say racism, just so we can get a sense of, you know, where everyone's at before we kind of fill these things in. All right, so if we could pair off again, and we'll see you back in 5 minutes. Steps of what we can do about them. So I'm not going to have any group reactions, so just hold on to that for yourselves. But I do wonder, you know, if anyone thought, you know, found it difficult to describe either race or racism, and has a sort of like feeling of, you know, I know it when I see it, which we will get to. And you know, I bring that up just because that original concept of, well, I can't describe it, but I know it when I see it, was actually, you know, was actually the argument around pornography, right? So it's like, I know I know that something's bad when I see it, but it's difficult to make that discussion. And we're going to try to move beyond that. We're trying to understand race and racism. And this is just the understanding, you know, I think about these things as a physician and as a professor, as like anatomy, right? Not everybody knows all of anatomy when they come into medical school. They don't know where the parathyroid is. You yourselves might not know where that is, but we know what it is. We know it's a thing, and we can teach you what it is. And the attitude there is like, oh, something I didn't know, and now I've learned. And so when we're talking about, you know, race and racism in the social sciences, you know, these things are understood pretty well by the social science community. And I think it's akin to that, right? It's not like, oh, don't tell me, you know, this bone is called the humerus, and I'm not sure, is that really true? It's just as true as anatomy is, right? So what we understand is that race is a social construct. It's a social power construct, and it really has no meaningful biological basis, right? So there is not really a meaningful or reproducible biological difference between the races, particularly in the way that races have been classified. But racism, however, is very real. So if we think about race as some mechanism by which certain groups benefit and certain groups do not, and then racism as a way of reinforcing that, then those effects are real, even though the original distinction is not biologic, but is really social. And so if you think about the census would tell you that we have 5 official categories for race: white, American, Black or African American, American Indian, Alaskan Native, Asian, and then Native Hawaiian Pacific Islander. So someone like myself whose family is from Mexico, I would not put down American Indian, Alaska Native, because that's not the culture in which I grew up. So, you know, I guess I would be asked on the census to put white as my race, but I actually don't think that that is the way that I am treated or the way that I identify myself. So it calls into question who gets to decide who you are or who you get to be. So racism. So racism is a system of oppression, which we've discussed, whose ideas, actions, and policies support a hierarchy of power based on race. And so in this country, racism is primarily about supporting a hierarchy of whiteness, of white as a normative basis, and then white as the group on top. So then where did this concept of race come from? If it's a social power construct and it's in the United States engineered to maintain the supremacy of people who call themselves white, then where did race come from? So this is from the work of Ibrahim Kendi, who has gotten a lot of publicity and support that's all well-deserved these days. Race was constructed, you know, as a historian, he found that race was constructed to justify political and economic self-interests that benefited from inequity, right? And so where that initially came to be was it was advanced by Portuguese slave traders, justifying their lucrative practice of stealing people from Africa and selling them as slaves. Prior to that, you know, people have always recognized distinctions between one group and another, but those distinctions were based on clan or based on geography or based on religion. But this concept of like separate races was actually a historically newly formed construct, in particular the way it gets adopted by America. So, you know, how do you justify this concept of race? So Carl Linnaeus, who is responsible for the creation of Latin binomials in biology, he tried to give his classification system to give some scientific basis to this concept of races. And so he came up with 5 races: Americanus, or the red people, so that would be who we would now call Native Americans; Europeanists, or the, which is distinct by white; Asiaticus, yellow; and Africanus, black. And those were the 4 categories. And he had all these other ideas about, the Europeanists are ruled by intellect, and the Americanists are ruled by ritual, and the Africanists are ruled by emotion, and all of these supposed categories that were then scientifically supported, which is all make-believe, right? Which was all just trying to force onto human difference a couple of categories that conveniently maintained the political and economic self-interest of those people pushing those categories. And to further, prove how much this is all a fairy tale, there were 5 races. And the 5th race that Carl Linnaeus actually created was called Monstrosus. And this was sort of his grab bag for pygmies and giants and, dwarfs. And so he actually believed that they were all a different race of people. And so you can really see that, like, none of this should have been taken for true at any point, because it's all make-believe. But yet these things closely track the races that we see even now in our census. So to continue on sort of that, the question of science and race, so the Human Genome Project, which, which copied out and identified and mapped the entire human genome. Craig Ventnor, one of the people involved in that project, one of his findings was that the concept of race has no genetic or scientific basis. That was one of their findings when they mapped the human genome, and that there is more genetic variability within populations than between them. And so to give a category of black and to assume that there is any biological through line between people in Algeria and people in the south tip of Africa is just not accurate. So let's break down a couple of ways in which racism operates. So structural racism is kind of the totality of ways in which racial oppression operates. And there's a couple of underlying mechanisms. So institutionalized, interpersonal, and internalized. And so we'll just go over those briefly. So institutional racism are the systemic policies and norms created by people in power that perpetuate differences in access to goods and services, and they reinforce what is possible or acceptable in favor of a dominant group, which is usually the group in which they find themselves. So if you look at these 10 people, these 10 powerful executives, does anyone have a guess who these 10 people are? What organization they represent? So these 10 people are the last 10 presidents of the American Medical Association. And so if you were to look at the statistics on the class of incoming medical students, for the last several years, this group is highly selective from that. It does not match at all who's actually going to be doctors. And so you see, a definite preference for white and a definite preference for male in this power structure. To give another example, looking again at the American Medical Association, in 1935, the Social Security Act initially included a call for universal health care. So 85 years ago, we had an opportunity to have universal health care, right? Compared to now, when it's still something that is up for debate and potentially on the chopping block. And that was removed due to protests, chiefly from the American Medical Association. And the American Medical Association refused to speak out against segregated hospitals and medical societies. And that actually caused African-American physicians to create their own organization, the National Medical Association. The first Black AMA delegate was not accepted until 1949, and AMA bylaws did not ban racial discrimination until 1968. And so there's a reason why power accumulated with one group of people within, within the House of Medicine, within the American Medical Association. And there's a reason why the AMA, didn't speak out against segregated hospitals and medical societies, because it wasn't a concern of the leadership, who were all white. So to give another example, here are 10 more leaders of another health organization. And these 10 are the last presidents of the American Public Health Association. So you can see a group that looks much more like the diversity of America, and the diversity of America in terms of race and in terms of gender. So it's possible for institutions to change, and it's possible for them to grow and to address some of those institutional differences. So let's talk about interpersonal racism. So interpersonal racism is usually what we mean when we talk about racism, when we say that's racist. And that's usually the bias and stereotypes that people espouse verbally about each other, and differential assumptions and actions based on race. And so this paper, called Unequal Treatment, is from the Institute of Medicine, and they were looking into racial and ethnic disparities in healthcare. And what they found, and you may find this yourselves within your religious congregations, is that the vast majority of people within medicine endorse egalitarian and non-racist attitudes. And the research also suggests that stereotyping and social categorization are prevalent universal processes. So what we have in medicine, and what you may find, or at least what I found in my own faith community, is the racism of the well-intentioned, right? So there's not the blatant racism that is stoked by far right and white supremacist organizations, but the racism of the well-intentioned, where stereotypes and social categorization work their way in to people's mindset, which then works into policy, which then causes differentials, even though most of those people support and espouse egalitarian attitudes. So one of the questions we have to think about then is, how do we address interpersonal racism when it's not the blatant racism of, say, segregationist 1950s, but the racism of the well-intentioned today. And then lastly, internalized racism. And internalized racism is really the acceptance by members of stigmatized races of negative messages about their own abilities and intrinsic worth, right? So this reflects systems of privilege, societal values, it erodes individual sense of values, it undermines collective action. So if you think that all the people to look up to are of a race different than your own, then that's going to undermine your sense of yourself, you're going to undermine your sense of importance in your own community. And those are all ways in which internalized racism affects people of color, but it also affects white people in a sense that members of the dominant racial group, in our case white, accept their own superiority and feel that it is appropriate that the orientation of society be around their experiences and their priorities, right? So it's not just about people putting themselves down because they've received negative stereotypes, but it's also about the situation in which white people don't feel like they're losing anything by living in a white world developed for themselves, right? That actually that's normal, or that that's even desirable, and that other people need to adapt and become more American, which obviously would mean white American. So if we are trying to oppose racism, first we need to identify racism and how it is operating. And so we need to oppose policies, ideas, and activities that reinforce a racial hierarchy. So we need to name those things and then develop alternatives for them. And then we need to act for those policies that eliminate disparities based on race and racial hierarchy. So Denise Rogers, who is actually, I believe now she's the dean at Brown, but her challenge, and this is a challenge to us in medicine, but I think it's a reasonable challenge to any institution with a moral mission and shared values, is that we never talk about racial disparities without talking about racism. Because if we talk about racial disparities in the context of a racial society in the context of racism as a huge system of oppression, then you can start to get the sense that there must be something different between races that justifies the differences that we see, or the reason why one group is imprisoned more than another, or the difference in socioeconomic status. And there is a reason, but that reason is racism. That reason is not within the bodies, minds, and souls of the people most affected. So we need to make sure that whenever we look at racial disparities, make sure that we're centering that conversation around racism. So to summarize, race is a social power construct. Racism is very real in a racialized society, and that structural racism operates at the institutional, interpersonal, and internalized levels. The other piece that's important to recognize is that since race and racism were created and learned, they can be unlearned, right? This is not a biological fact. This is not a physical property of the universe or a biological process, but it's actually something that we've learned, and therefore something that can be unlearned. And therefore, anti-racism requires both awareness of racism and active efforts to dismantle, right? So it's not enough to start to learn the language or to go to the training and understand what's going on, but there also has to be that follow through with active efforts to dismantle that issue once you have named it. And it's important that we remember that the starting point is that racism kills, and it does so on a grand scale, right? So I know that it's uncomfortable to have conversations about race, that it's uncomfortable to consider the ways in which you have attitudes that are when examined, embarrassing or abhorrent to yourself or to your higher values. And all of those things are real, and that uncomfort is real, and that discomfort, it's important to work through and figure out how we can address it together. But it is in the context of, that racism is actually killing people now and presently. So we can't get hung up on our own process when the things, it's basically like if the building's on fire, the fact that it's uncomfortable to be running into it to try to rescue people is actually secondary to the actual reality that the building is on fire, right? So, let's take 5 minutes to just get, I know I threw a lot of sort of concepts and things at you, and didn't have a lot of time for discussion. So let's take 5 minutes and get anybody's reactions, questions, comments, challenges, what have you. So then I have a question. So if this is taken by your silence, not news to anyone, then what is the place that you are trying to get to next then?
I'll just say that, I've been trying to deep delve into the topic of racism in particular for, really hard in the last several years. And I feel the unlearning part overwhelms me when I just really want to put it out on social media and have everyone accept that racism is a social construct and we need to unlearn it. It's the taking the steps in the unlearning, which I feel like it's taken me years just to have tiny steps of understanding and how to bring it to your community gently when you want to take giant steps. That's what overwhelms me is the unlearning piece and the how to step into it gently together. But it feels right now like something that needs to happen faster than I am, than I think most people are ready, you know, especially if you haven't stepped into it yet. Just so the whole stepping into the unlearning as a society overwhelms me a little bit.
Yeah, absolutely. So, you know, I appreciate the frustration with wanting things to be better faster, and it makes me, it actually makes me think about, so, you know, when was it that you first, and this is not just a question to you, Debbie, but to anyone really, you know, when was it that you first sort of started thinking about this concept of race or racism? Like, when was that first exposure to that? You know, I'll give an example. So a classmate of mine from medical school and a friend of mine, Rob Jones, who's Black, he was wearing a Black Lives Matter shirt, you know, a couple of months ago in Costco, and like right at the beginning, right after George Floyd had been killed, and the sort of resurgence of Black Lives Matter into the mainstream conversation. And somebody asked him, "Where'd you get that shirt?" And he said, "Oh, my college made it for me, and I had it from there." And he's like, "Oh, how did they know? How did they get him out there so fast?" And it's like, well, that shirt was made, you know, back in 2014, like when Black Lives Matter started, not now in 2020 when this person asking the question thought Black Lives Matter started. So it's interesting, you know, when do you get on board, and then when do you think this conversation started? So I want to switch gears to COVID-19 now that we've laid some foundation around health equity, and how racism plays into that. And then we can look at how these things play into COVID-19. So just briefly, I wanted to get people's, just a temperature check on what people know about COVID-19, or what are their questions about COVID-19 and who it affects, you know, how it works, anything like that.
My understanding is that it's a very virulent flu strain, or at least in that class, that does not discriminate based on age or anything like that. But however, our system discriminates in the aspect that people with better insurance and better coverage and better access have a higher likelihood, not 100%, but a higher likelihood of actually surviving it.
Mm-hmm.
And that even if you do survive, and depending on how long you're affected by it, your road to recovery can be still months and months long. And they are discovering that there may, and they don't know yet, because we don't know that not much about COVID-19, that for certain people, it may actually leave permanent disabilities in breathing and ambulation and in other areas. The only thing I can make it akin to is like a stroke. And receive, and particularly medication and other stuff. So yeah, that's what I understand about, as much as I know about COVID, and I know very little.
Very good. Anyone else? All right. So, so we're going to talk about the different ways in which COVID affects different groups. So, you know, one of the main distinctions that we see with COVID-19, which is the disease caused by SARS-CoV-2, the organism or the virus, is that it is much more dangerous and much more fatal to the elderly. And that's elderly by biological age. So the older you are, the rate of mortality goes up, which, you know, is not the true of the flu, right? The flu is most dangerous to the very young and the very old, but the very young, thankfully for COVID-19, are not by and large very much affected, and that the mortality rate is low. But as age goes up, the risk of mortality goes up. And it's not just biological age, it's also, there's a concept called weathering. And that concept of weathering is basically how much stress load or how much sympathetic load and have you been carrying in your life. And so that concept of weathering is important for understanding differences in life expectancy by race, because one of the things we find is that the constant pressure of dealing with the effects of anti-Black racism causes weathering on the bodies of Black people. And so they are, being harmed, in an invisible way, but in a way that ages them just as surely as time does, by the suspicion, by the discrimination, by the comments, by the looks that all constitute racism, by the opportunities lost. And so not only do we see more chronic disease amongst communities of color, but also higher mortality rates. And part of that is due to this concept of weathering. So as an example, this is, and then there's also the cultural context and the social context in which people live. So these are some drawings that were made, some comics and posters that were made about people, about essential workers, right? So Amadeo is a strawberry picker in California, and he's saying that nothing has changed at work. The distance between is supposed to be 6 feet does not work in agriculture. I worked for many years and paid taxes, but I'm undocumented and have no access to benefits. So all of those now gone unemployment benefits that citizens were able to potentially take advantage of, not available. If work hours are cut or we contract the virus, we can't pay rent and we can't go homeless, and so we have to work. And how are we going to fill those bills? And so that is a very different scenario than even for myself as another essential worker, as a physician, who, when I'm teaching the medical students, I do it from home on the computer with a hotspot that was given to me by the university. And yes, it causes some difficulties in the transmission, and we don't have a good group conversation in the same way, and it affects our care a little bit. But it's certainly not putting me at risk of death just by showing up for work as a professor. And when I go to work in the hospital, I have all the PPE I need and all the protections to try to stop that transmission. But if we're both essential workers, then there must be two different types of essential. So the concept that I kind of liken this to is that we're all in the same storm, but we're not all in the same boat, right? So it's the resources, the position that you have in society impacts how well you can weather this storm, and that's important. So if we're looking at a couple of examples, and this is in Washington, so well, it's across the nation. Agricultural workers were initially exempted from minimum wage. They're still actually exempt if the farm has less than 500 man days a year of work. And then agricultural workers are exempt from overtime, which is a federal policy, which Washington State adopted that federal policy. And then if we look at healthcare as another social determinant of health, non-citizens actually have a 5-year waiting period to utilize government services. So that's not people that are undocumented, that's people with a green card. So, the government has said you're fine to be here, but because you're a non-citizen, you have a 5-year waiting period. And that undocumented, that was reaffirmed in the Affordable Care Act for all the good it did. It still maintained this system, and the undocumented are explicitly excluded from the Affordable Care Act. And so as a consequence, the largest growth of uninsured since the Affordable Care Act was amongst undocumented people, right? And so they now make up the largest percentage of people who are undocumented, who are without health insurance and therefore without access. And so when you look at this disparity data by race and ethnicity, and this is from the COVID tracker, this is for Washington State, what you see is, this is broken down by race and ethnicity, and the percentage of the population that race represents, the percentage of cases that they represent, and then the percentage of deaths. So everywhere you see a triangle, there's a disparity in the percentage of cases. And so you can see that, there's a 50% increase from what you would expect based on population for Black and African Americans, and for Hispanic and Latino, that's more than a 3-fold increase, right? And then for Native Hawaiian Pacific Islanders, that is many-fold. It's a smaller population, but it's again represented. And so why is it that these groups, if as Linda said correctly, that the virus doesn't discriminate, why is it that their percentage of cases are different? And that is really in the social order, right? It's in the social determinants of health. So here's an example from Oregon. So this is Oregon's data, and the same thing you see, actually the Black disparity is worse. It's double in terms of percent of population. And in Oregon, they prepared this data differently, so they go by race first, and then they had a separate one for race and ethnicity. And you see similarly that there's a huge distinction in the Hispanic and Latino in terms of percentage of cases. And one of the primary reasons for that is the agricultural, is the job opportunities and the work in which those communities find themselves. So where does that come from? Why is it possible that we get this distinction between one community and another? And so I want to tie this back to some of the historical underpinnings that made, that underline why it was predictable and was predicted that, that minority populations would be more affected by COVID. So this is Spokane, and this is actually a map of life expectancy by neighborhood in Spokane. So if you look down at the south end of it, you can see Southgate, and Southgate, people who live in Southgate have a life expectancy of 84.03 years. And then if you roll north and a little bit to the west, you can see Riverside, where people have a life expectancy of 66.17 years. So there's a 18-year life expectancy difference. And this is in Spokane, if you're not familiar, Southgate is the top of the South Hill, and then you roll down the hill towards the river, and then people are living 18 years shorter lives. And this can't be due to access to hospital services, because the hospitals are all based in Riverside. Deaconess and Sacred Heart are both down there. So there's something else that's making the distinction between why people in Southgate live 18 years longer than people in Riverside. So let me pull up another screen so we can look at some of the historical piece of this. That's Portland. No, this is Spokane. So the reason historically why you see this distinction is because people lived in different areas, and segregation and by race and by region were kind of built in by this concept of redlining. So redlining was really about who got access to government mortgages and who didn't back in the New Deal, and certain areas were excluded. And so you have to decide what's a good place to lend and what's a good place not to. So the U.S. government actually, commissioned people to go out and create these maps, right? And these maps are color coded. So the red areas are the areas where you should not lend. And, it goes up to yellow, and then it goes up to green to blue for more desirable places. And so here in Spokane, the Riverside is down here. And the people who surveyed these maps and created them, they wrote down the reasons why they said this was a red area. And so it's instructional to look at what they actually thought. Part of the clarifying remarks for why this neighborhood was red was that many foreigners live in this area, including a few Orientals and many Finns. And if you come across the river up here to the other part of Riverside, you see that 2 or 3 Negro families in the area was a reason for it having a red marker. And if you come over here and look at here, this area, which is East Central, it's immediately adjacent to Liberty Park, which is better grade, but the proximity to the largest Negro concentration of the city precludes a higher grading. This is the melting pot of Spokane. the area is accorded a low red grade. So they weren't using melting pot in a positive multicultural sense, but in a pejorative, don't go in that neighborhood type of way. And so this is in Spokane, but they also map these out in Portland. So we can look at Portland, and there's been lots of changes in who lives where in Portland due to influx of money. But if we look over here on the west side of the river in Portland, Oregon, in the northwest, the western part of the area is of better grade, but subversive racial elements are prevalent in all parts. The area is accorded a low red grade, right? So it's pretty explicit the reason why this area of town is not a good area of town. And it's because of racism. And again, we see this area constitutes Portland's melting pot and the nearest approach to a slum district in the city. 3/4 of the Negro population in the city reside here, and there are some 300 Orientals and 1,000 Southern Europeans and Russians. And so it's really not subtle how we got to where we are in terms of racial segregation. And that's important in the context of COVID because if you look at what are the reasons why we have differentials in health based on race. So David Williams has done this work, and what David Williams found reviewing the literature was that socioeconomic status, people's income, it explains a little bit of the difference between white and black. That doesn't explain it all, but residential segregation by geography, if you remove residential segregation, it essentially normalizes the life expectancy between white and black people in the United States. And so it's that residential segregation, which was created in large part by government policy supported by industry, that is responsible for the difference we see, which then is responsible for why it's easier to get arrested in one of those neighborhoods. It's the school. It's harder to find a good school for your kids. It's harder to find a job. It's harder to have good streets and working streetlights and all these things. And it's also why it's easier to die from COVID if you live in one of those communities. So if we go back to the very beginning of this presentation, I talked about Ruby Atkins, who died in New York of COVID-19, and she had so many more risks. She was so much more vulnerable to dying of COVID because she was a ward of the state, living in a nursing home that was having her mental health issues treated essentially by being given enough medication to not bother anyone. And all of those things play out along her being a poor Black woman, with mental health issues. And so from this history directly into now, the cost of inequities is present. And as I said, was predictable and was predicted. So what do we do about this, right? So all of this is very distressing and very disappointing to know about and to acknowledge. And so what do we do about it? So this is from the World Health Organization. This is their Commission on the Social Determinants of Health. This is their report on it. This is from 2017. And they said, first of all, that we can address these social determinants and that there are 3 things that we recommend for doing that, right? And that's why they titled this Closing the Gap in a Generation. 1, improve daily living conditions, so address those inequities and resources. 2, tackle the inequitable distribution of power, money, and resources. And then 3, that we need to measure and understand the problem so that we can assess the impact of our actions and try to be more effective, right? And so the key piece that I want to leave with you and share with you all is the inequitable distribution of power, right? So, I work with the Metropolitan Alliance for Common Good and the IAF Northwest, and those community organizations are primarily around power, because it's not just prejudice, which is I think I'm better than somebody else, that allows systems of oppression to exist. It's prejudice plus power where something becomes oppression, right? So it's the ability to enforce your prejudices upon the rest of society that lead to these disparities that we see. So in community organizing, we talk about how all organizing is disorganizing and reorganizing again, right? So we've been talking about race and the concepts of racism and all these things so that we can understand the world as it is. And then our goal would be to disorganize that and to reorganize it in the direction that we want, right? And so what is it that we want to see? So I want to pause for a second and just get anyone's, leave a space for people to react or questions or comments they have so far.
Well, I'm struck by how many layers there are to all of this. And as I listened to Luis and kind of taken in what you had to say, I remembered being raised in a family who had privilege in the Chicago area. I was raised Roman Catholic, and we were just raised to believe we were better, but just kind of a fact that the Catholics were going to be first in line in heaven. Sorry to tell you that, Lutherans. So I don't know why I left the Catholic Church, because I lost my place in line. But anyway, but it was just kind of a given. And for me, it was more a question of class than race. We also lived in a community that had we were very close to a lot of African-American families. And for me, that just felt like a norm. I was aware of disparities, but in terms of feeling like I was better than, I knew we had more financial means, but I didn't feel better than. It was just more the class and religious bias that I felt more strongly. But I'm struck though, kind of as we try to unpack that as adults, I love this statement of how do you disorganize and reorganize? It's also how do we reorganize our thinking? Because that was just a given in my life until I got to be an adult and go, oh, that was so wrong. So I think what you're helping us understand is how do we continue to learn and grow and be willing to look at our privilege, to look at our biases, and to really understand and embrace some of these concepts and move forward and reorganize. So thank you for all the ways you've helped kind of make us think today.
Oh, thank you, Sue. So, I think, if we go back to, I think that's very well said. If we go back to that institutional, interpersonal, and internalized racism, what is that speaks to the, how are you going to kick out the colonial mentality, the mentality that's been put into your head around race, whoever you are, and how are you going? And then what is it actually that you want to take its place, right? So any other comments?
I just wanted to call attention as well to mental health, which is linked to physical health, obviously, and how, sorry, I didn't have my video on. So I was in a workshop recently about mental health services and the inequities there. And this is also going on in that field as well, as you might expect, but everything from the Diagnostic and Statistical Manual, which is formed by committees, and those committees are mainly white people, and everything to people of color lack equal access to mental health care. And when they do have access, they are often overdiagnosed or misdiagnosed, and not given the proper treatment. Like I said, the very diagnoses that they're given are also can be prejudiced. And then there's just a lack of understanding of the trauma that's caused by racism, and how that affects the mind and the body. And so we're seeing a lot of inequity in that realm as well. So it's all and it's all connected, the physical and the mental health fields. Thanks.
Yeah, yeah. Thank you, Jeff, for bringing that up. It's definitely true. You know, in Tucson, Arizona, where I'm from, you know, the misbehavior or the acting out of white teenagers in Catalina Foothills, a wealthy neighborhood, is boys will be boys, or it's a mental health issue, and we need to figure out, you know, what's driving this and how can we support them, which is a great thing to do. But for the Latinx students in South Tucson, it's not a mental health problem; it's a criminal justice problem. And so it's really about punishing vagrancy or punishing, you know, inappropriate behaviors, and, you know, having a kind of spare the rod type of approach. And it's like, you can't believe both things at the same time for two different groups. And so either, you know, all of these teenagers need to be criminalized, which I think is a terrible idea, or the idea of addressing mental health needs to be opened up equitably. And then, as you said, the cultural context of that, which would require addressing the cultural context. So let's move on so that we can get to some group conversation around this, and looking back into your institution, the Oregon Synod. So what do we want? What are we trying to create? So I would say, you know, and this is from the Zapatistas in Mexico, an indigenous autonomous region. So they say, queremos un mundo donde quepan muchos mundos. And what they're basically saying is, what we want is a world where many worlds fit, right? So they want the opportunity to be themselves. And so, you know, I feel like that sentiment is very much in keeping with, you know, when we're talking about Time's Up, or we're talking about Black Lives Matter, or we're talking about, you know, all of these ways in which, you know, even the civil rights movement, the Black men on strike saying, "I am a man," like, all of these things are about recognition and providing some space to be who you are and to be able to do that with those people around you. And what that is disorganizing is in our context, a culture that's focused around whiteness as the mainstream, but it's also maybe even giving up the idea that anyone should be in charge of everybody else, right? Like, that maybe we can just all come from different places and have a, you know, a pride in who we are, and also a respect for people that are different than ourselves, but that it doesn't have to be just one way, right? Whoever that, you know, whatever that way may be. So let me give you an example of disorganizing and reorganizing again connected to COVID. So this is a photo of our team in Spokane. So, you know, one of the things that we knew going into the COVID pandemic was that different groups would be differently vulnerable and differently at risk. And so we knew that the incarcerated were going to have a huge risk of coronavirus outbreak, and that might fuel further outbreaks in the United States, where we imprison more people than anyone else on earth. And then we knew that amongst the homeless, you know, people who don't have a choice around sheltering near other people or don't have as much access might also be at risk. And so what we were able to do, we had previously talked about creating a street medicine team to try to meet the needs of homeless patients, and to try to give up the assumption in healthcare that everyone has a car, has a home, has insurance, and can just come into the office, and if they don't do that, they must not care about their health, right? So we're trying to actually meet people where they're at. And so this whole idea of a street medicine team is around that, is around, you know, meeting the specific and different needs of a population, so that we can address the inequities that exist in their health, and so that we can plug them in, right? So if the alternative is ignore them versus figure out how to actually meet somebody's needs, we were moving towards meeting someone's needs. And so we utilized the COVID pandemic, which was disrupting the healthcare system and the way we were doing things, and, you know, all the clinics were going to telehealth and all this stuff. And so all that stuff was very disorganizing for healthcare. And so we utilized that opportunity to try to organize around something we were trying to do anyway, which was to create a street medicine program. So we said, we will go out and we will do the COVID testing for all the people on the street and in the clinic and at the shelters to protect all of the people who are housed from potential spread of coronavirus amongst the people who are experiencing homelessness. And also, this will allow us to create the infrastructure to actually take care of homeless people with their own needs. Because we have a lot of well-meaning efforts in healthcare in Spokane. There's even a House of Charity clinic, which was created specifically for the homeless population, but they don't see as many people as maybe they could, because even though they are standing there with open arms waiting to receive people, that's just not the life experience of many people on the street, that they're gonna go to the clinic and follow through and these type of things. So we are taking the opportunity to meet them where they are and address their needs. So we've kind of reorganized healthcare around that focus. And this is, Brent Conrad, who's a fourth-year medical student, who plans to go back to Colfax, this rural town in Washington, and practice rural family medicine. And what he's learning in this context is how to create a healthcare system where many people can be served, right, where many people fit. And I think that's if there's any silver lining for me in this whole coronavirus pandemic, is that we were able to get this program started. We were able to use this crisis as an opportunity to address an inequity. And that inequity is not distinctly around racial lines, but we do see that particularly the Native American community is overrepresented amongst the homeless population, and is overrepresented amongst people who are not going to come to seek care in the hospitals and clinics. And so, on that extent, we're addressing that piece. And on another level, we've been working with the Hispanic Professional Business Association to provide a monitoring and outreach program, and to provide materials in Spanish and that are culturally appropriate for people to understand COVID better, because Spokane does not have a large Latinx population, and so there aren't a lot of resources for them. It's different if we were in Yakima, where there's a lot of people that speak Spanish and a lot of people therefore providing services that are consistent for that community. So anyway, when I think about the challenge to myself of, what needs to be disorganized and reorganized, the concept of the clinic where you show up and drove yourself in and show up 15 minutes ahead so you can fill out the paperwork so we can have the visit, is what we needed to disrupt and break down so that we could actually organize it around, like, what are the needs of people where they are. And so we were able to create the street medicine program. So that question, then I would turn back to you. And what does that mean for the Oregon Synod and all of your communities within that, within your larger faith community? So if we could, let's see, there are 9 of us now. So if we could just break up into groups of 4 and take a few minutes thinking about, how could you imagine, as we had talked about racism existing on an interpersonal, institutional, and internalized level. At an institutional level, how might your faith community help take up this question, these inequities that COVID has made plain, even though they've been there forever? And how might the Synod support individuals in addressing interpersonal or internalized levels of racism, which lay at the heart of racial inequities? So if we could split you up into 2 groups, and then we'll just take 10 minutes and then we'll come back together and think about it as a group a little. Yeah, we've only got about 5 minutes left, so I did want to bring up a, oh, it didn't work. So there is a, thinking about an institutional example. So, one thing that struck me is the, which no one has brought up, but is the massive outpouring organizationally and institutionally to make statements affirming a commitment to anti-racism or a desire to address racism or to recognize it or what have you. And so, I think that's both good and bad. It's great in that it's a recognition, but I also am concerned about how much it is a relief valve in which it's kind of like a way of channeling effort that doesn't challenge underpinnings. And so, looking into it, so there is an international convention, the International Convention for the Elimination of All Forms of Racial Discrimination or Discrimination Based on Race. And that's a UN convention. Do you think that the United States signed on to that convention?
Since you're asking, probably not.
Anyone think that they did? Have more faith in your country. Yes, the United States absolutely signed on to the International Convention for the Elimination of All Forms of Discrimination. Not only that, but they reaffirmed it. So they signed it in 1968 for the first time, and they reaffirmed it in 1995. And every year, the working group of this committee sends a report to the United States based on their findings around racial discrimination in the United States. And they say things like, we are still very concerned with the levels of incarceration and police violence against communities of color. And so, I think this example, it really pulls out to me the importance of power in this conversation, because, if you read the convention and the things that they've done, all of it is actually very impressive and is a recognition in the international community of the US's interest. But, I don't think it has had much impact if I've never actually brought this up and had anyone know what it is. And I've never had anyone believe the United States actually signed it. So it speaks to, and this was also something that, the first person that taught me about this was Kamara Jones. And it really speaks to the limitations of well-intentioned language or well-intentioned or, high values on paper, and if not in practice. So, as you're thinking about it, and I like the concreteness of everyone's suggestions and the work that's going on within the Synod and within your congregations around trying to address these issues. So I want to leave you with a quote from James Baldwin, and this is how he closed the fire next time. So if we, and now I mean the relatively conscious whites and the relatively conscious blacks, who must, like lovers, insist on or create the consciousness of the others, do not falter in our duty now. We may be able, handful that we are, to end the racial nightmare and achieve our country and change the history of the world. Right? So that is towards achieving our country, which is a necessity, even though it's never been a reality. So I wanted to leave some space for any questions as we close, and then just this poster I found about the pandemic created by Ricardo Levine Morales, who documents all sorts of organizing and social efforts.
Is it possible to have this questions things with all the animals and the suggestions sent to the Synod or somehow that we can have that and send it out? Because this is a wonderful, non-forceful depiction of how to care for each other.
He actually, so he's an artist, and if you go to his website, I think it's rlmartstudio.com, you can buy copies of this poster, you can get digital versions, all that sort of stuff. Yeah, I found it on the hospital, actually. One of the care managers had it on their door, and I was really excited to see his work out in public a couple months ago. So we're at 4:30, so I want to be respectful of your time and thank you for spending the last 2 hours with me. Yeah.
Thank you so much.
Yes, thank you.
Wonderful.
It's been great having you with us, and we really appreciate your time. So,
Yes,
thank you.
Thank you for fitting us in.
Thanks, Luis. Nice to see you.
Yeah, nice to see you again, Sue.
Yeah, it sounds like you've landed well and doing work that's very meaningful.
I'm good.
Good.
All right, take care.
Take care, everyone.
Thank you. Bye.